about health economics.
What I'll do is I'll try to give you.
What I'll do is I'll try to give you.
But I'll give you an overview of it, obviously. But I'll give you an overview of
we would need something like
why we would
how
need
it
something
works,
like
and
health economics, how
what
it
it
works,
actually
and
is,
what it
in sort of a
actually is,
contemporary,
in sort of a
healthcare
contemporary
system.
healthcare system.
So first of all, let's talk about why.
So first of all, let's talk about
this.
why we would need something
So
like this.
around the world, and especially in
around
the
the world,
Asia-Pacific, what's
and
happening
especially
now
in
is
the
the
Asia-Pacific, what's
populations
happening now
are
is
getting
the
older and older.
populations. So
getting
on the
older
left
and
side
older.
here, I put running a little bit behind.
You are running a little bit behind.
Population will also grow dramatically.
Population will also grow dramatically.
And what this means is that
And what this means is that
pressure
it'll
on
put tremendous
funding
pressure
of healthcare
on
and healthcare
funding of
systems in
healthcare
general, because
and
older
healthcare
people just
systems
need
in general,
more
because
healthcare,
older people
and it's
just
getting
need
more and more
healthcare, and it's getting more and more
nowadays.
complicated nowadays.
And for example, what we see now is that people instead of dying of
cardiovascular disease and complications,
as was the case a few years ago,
as was the case a few years
in
ago.
fact, in the Western world, we see more and more people die of cancer.
It's a very, very complex
disease, as you all know.
And in fact,
when we look at sort of the newer cancer medicines,
and so this is a chart of
new medications to treat cancers in Australia.
And what I've done here, I've looked at these new
checkpoint inhibitors.
And as you can see here, the cost of these medicines,
7-8 years ago, where we paid less than $100 million
has grown almost exponentially, and the cost last year was more than $800 million
healthcare system in Australia.
And as more and more people are living longer and getting cancer, we would anticipate the cost of healthcare
within this area dramatically.
Now, the current situation with COVID-19 and coronavirus has exacerbated this.
So chart from
the US
the
that
expenditure
in terms of just
the
treating
expenditure
COVID-19,
treating
in the US
COVID-19
in the US
very
actually
high.
As you can see here, it's anticipated that 20% of the population got infected, then this would amount to more than $200 billion
$200 billion
and
US dollars.
If indeed 50% of the population got sick, then they would have to spend more than $400 billion.
They would have to spend more
and
than
this is money that wasn't.
And this is money that
should we say
put into budgets.
Should we say
early into budgets?
And so this money will have to be taken out.
This money will have to be taken out of
products,
other healthcare
and services,
products,
just to cover this,
and services, just to cover
and
this.
Therefore,
in this sort of whole
environment,
healthcare
as I sort of alluded to,
people live longer.
As I sort of alluded to, people live longer. Treatment is getting more expensive.
On
budgets and resources due to COVID-19.
So we really need to start
thinking about how we have sustainable healthcare in the future.
So allocating our resources.
So allocating our resources,
and it's not just
in an efficient way,
and
money,
but it's also about money.
So
but it's also about
Professor Jimmy just explained, right?
It's also about how explained, right? It's also about how the resources within the hospital,
in order to combat COVID,
in order to combat
COVID,
and obviously and grow them for that, then there's other
and grow them for that, then there's other
and there's a big worry here in Australia that
and there's a big worry here in Australia that people will die of other things than COVID because we are not able to service and help them. So
a lot of the screening programs we usually run in terms of cardiovascular disease and cancer, they've been on standby. A lot of elective surgery has been on standby because we've had to deal with COVID, and therefore people are dying of other things, which is really not that great for us.
So that's the why we would need something like health
So that's the
economics.
why
Now,
we would
let's
need
talk
something
about
like
the
health
how.
economics. Now, let's talk about the how.
Health economics
Health
is
economics is sort of a field of academic research where we look at optimal allocation of resources and funds.
We think about
we think about what medications and services should we fund, how should we make them available,
should we give it to everyone,
or should we give it to everyone, or should we restrict it to the very sick,
and who should receive these services,
and who should receive these services and goods.
And what we talk about in health economics is
cost effectiveness.
Cost effectiveness is really down.
Cost effectiveness is really down to value of money, value for money. So, is the services that we fund, are they good value in terms of health outcomes? And then we talk about what are we willing to pay for these services. So, unfortunately, it's not about saving money. Always, it's mostly about getting the value for the investment. So an example I haven't put in here, but I probably should, is, for instance, vaccinations for COVID. It's actually a no-brainer for health economists. We pay less than $100 for vaccination, and I'm thinking about, it's not just the vaccination itself. It's also the salary for the pharmacist to dispense it, the remuneration for the nurse to actually administer the vaccine, and so on. It could amount to around $100, but the effectiveness we get out of it is we know that people who are vaccinated have very little risk of making it into hospital, and even lower risk of them having to go into ICU and later onto a ventilator. And then, of course, that resource that we save is so cost effective compared to the $100 that we paid up front, which is why health economists nobody really argues that vaccinations is a good thing to do from a healthcare perspective. Now, we need to talk about who pays for the healthcare. So in the US, they've got an insurance system often tied up to the employment. So if you work for a company, say like Pfizer, then Pfizer would have their preferred health insurer, and the Pfizer would then pay for their employees, so they have healthcare benefits. In Australia, it's a government subsidized scheme, so everyone in Australia, every citizen and permanent resident has access to healthcare. And medicines, for instance, are capped. So the price of medicines are capped at $41.30. Pensioners only pay $6.60. And that means no matter whether you have, a very expensive cancer medicine, the patient only pays $40. And in any given year, if the patient actually has, say, a chronic disease and they paid $1,497, then everything above that would be free for them. Now, obviously, this has a very large impact on the budget for the government, and therefore they need to closely look at what they spend every year. And then we've got countries or jurisdictions like Singapore, where it's a combination where there's health insurance, but you also pay a large co-payment. It could be several hundred, up to $1,000. So you sort of also, should we say, self-insure. You can sort of pay. You need to pay the hospitals and the providers yourself. So why does it matter who pays? Now I put an example here in heart surgery. So when people with AS, aortic stenosis, when the heart valve gets clogged up, then one thing we can do is we can replace the aortic valve, and current standard of care in many places is actually to do open heart surgery and then replace the valve with a mechanical valve. And so patients can then live or continue living with that. A new technology is this transcatheter aortic valve replacement, where it's actually inserted in through one of the larger veins. So it's not open heart surgery. Usually there's a balloon or a sort of a self-expandable mechanism. So the valve then gets inserted without this big open heart surgery. Okay, so let's unpack that. So here I've sort of put together just a hypothetical example of costs of this aortic valve replacement. And if we use let's start with the one on the right side. If we use the surgical valve replacement, then the cost of this valve would only be $5,700 here in Australia. And you would obviously have to pay the surgeon. We would pay him around $5,000, $6,000 to perform the surgery. And then the patient would have to stay in hospital afterwards. And in Australia, we say 6 to 7 days, which is costed around $7,000 per day in hospital. So it'd be $49,000 for the hospital stay. And then usually for these patients, they will get AF, arterial fibrillation. So they would probably need warfarin afterwards, and see specialists and have tests or ongoing tests and so on. And we estimate that to be around $3,500 the first year. And so the total cost of aortic valve replacement, surgical aortic valve replacement, would be $64,000 in Australia. Now, this new technology here, transcatheter aortic valve replacement, the actual device costs $29,000. So the device is much more expensive than the surgical device. However, the procedure can actually be done under anesthetic and by a cardiologist. And so you would only have to pay $3,000 to have the actual procedure done. And what we've noticed or we've observed in Australia is patients actually, in many instances, can actually go home the same day they've had the intervention performed. And therefore, the cost from a hospital perspective is very low. So I put $14,000 for 2 days. But what we're seeing now in our registry data is actually only 1 day, so it would be $7,000. However, around 15 to 20% of the patients would need insertion of a pacemaker afterwards, and pacemakers are quite expensive to insert in Australia. They're $15,000. So all in all, I've calculated for this intervention to be $61,000. So as you can see here, they don't really cost the same. They almost cost the same. So there's not a big difference. But then the question is, how would you choose which one to use? If it's just a dollar amount, then you would probably say, okay, we'll go with this one here. But there's some uncertainty with respect to the dollar amount. So for all sort of practical purposes, we would say they would be the same. But say you were a surgeon, then a surgeon, and this is what we see in Australia, they would advocate for this intervention because that's what they earn. Whereas cardiologists would advocate for this intervention because then they get remuneration for that. In terms of hospitals, public hospitals would probably prefer to transcatheter aortic valve replacement because they can get people out of hospital fairly quickly, and then vacate and use the hospital bed for something else. Whereas a private hospital that get paid by, say, the patient or by insurance company might actually prefer this model here because they get higher remuneration out of this. So this is just to illustrate that it's not a clear-cut case of just dollars and cents. It also depends on what and who the stakeholders are and what the customers, what they want. Needless to say, when we do quality of life and we look at quality of life for these interventions, patients prefer the non-invasive one, which is the TAVR or the transcatheter aortic valve replacement. Okay. So let's go on. So how can we compare these interventions and how do we do it in health economics? Well, we look at benefits. What benefits are there to the patient? Is it a cure? Do we have increased survival or quality of life? And we look at what benefits there are for the payers. Does it prevent disease in the future is one big thing that they obviously want to know. And then we also have to factor in toxicity and adverse reactions. And then lastly, when we do these big modeling exercises, we also look at the cost of the interventions and the benefits and harms afterwards. So it's a sort of a economic modeling exercise we do. Now let's talk about the what. So what are we supposed to do with this, and how do we do it? So I thought I'd illustrate a bit, or use an illustration of the Australian sort of system. So in Australia, health economics is actually mandatory when drug companies ask for reimbursement via sort of the government subsidized scheme. And so the manufacturer has to submit all the clinical evidence, and they have to show calculations how much it'll cost for the government in sort of a budgetary financial impact across all of Australia in the entire population. The government then has a panel, a committee, they're called the PBAC, the Pharmaceutical Benefits Advisory Committee, who sends the application out to academic units like the unit that I come from. And they then assess all the data that was given. And the committee then makes a recommendation to the Ministry of Health of whether this new intervention should be adapted or not. Other ways of policy regulation in order to facilitate spending is regulation of prices. So in Australia, when a drug has been on the market for 5 years, it has to have a mandatory price decrease of 5%. And after 10 years, it's a 10% mandatory price decrease. And patent expiry, so when the patent expires in Australia, it's basically a free market here. And the price will then, in most places or in most instances, drop substantially. And that means that there's actually value in the healthcare budget that gets freed up. And I'm just going to show a small example for what happened with atorvastatin. So atorvastatin is obviously one of the most widely used drugs for lipid-lowering agents, one of the most widely used lipid-lowering agents. And in 2012, it went off patent, it lost exclusivity. And then every year forward, it then had a price, we call it price disclosure, but it had a price decrease up until 2015, where it sort of stabilized and there was a change in sort of dispensing fee and so on. And what we did was we went in and calculated how much did the government actually spend on these drugs. So in 2012, just before the patent expired, the government was spending $600 million on this lipid-lowering drug. And in 2015, after it went off patent, we actually only spent $150 million on the drug. And that means there was a saving of $450 million. And that amount of money has now been reinvested in newer, better interventions. So this is sort of an example of policy, central policy from the government that can help free up finances and resources in the system. Okay, and now just lastly, I'll just present this slide here. So remember I showed to begin with that cancer drugs, and this is in millions, it's sort of exponentially growing. And now, the last financial year, the government paid $839 million for just those 5 drugs. But overall, when we look at the overall healthcare budget in terms of drugs, it's actually pretty stable. And since 2016, the health economics has actually helped contribute to the budget not spiraling out of control, and the government being able to manage the healthcare budget properly. So that's sort of what is it good for? It's actually, health economics is good for actually managing the healthcare budget. That's my postulation. And that's all for me.
Thank you, Mr. Han Soo Kim, for the presentation. And we will continue to the question and answer session. We have already got some questions on the chat box. And for the information of attendance right now, we are being watched by and being streamed by 827 participants. So I hope these the questions are not as much as the attendance today. Mr. Kim, first question, anonymous participant. Indonesia has a solution in health problem called BPJS, or Universal Health Coverage. What do you think of this? Can solve Indonesia's health problems? Please answer, Mr. Kim.
Yes. So before COVID in 2019, I was invited for a seminar with the PBGBS. So it was back then when Dr. Professor Iwan was still the chair, and unfortunately he got sick. So I was invited to discuss health economics with them, and I think one of the big challenges is the funding mechanism, and should we say the challenge of raising funds to get newer, effective medications to people. The second thing is actually, it sounded like there is a challenge operationally because Indonesia is so big. So my understanding is it's centrally run by some of the people in Jakarta. So it's not always transparent when things are being rolled out. And then the last thing is that Indonesia is very, very diverse, right? So in North Sulawesi, you have a large Minahasa population, and your public health challenges are not necessarily the same as what's happening in Central Java. And therefore, I think it might be advantageous to start looking at probably more provincial adaptation of these kind of systems. So I'll give an example. In Canada, for instance, the different provinces in Canada actually run their own healthcare systems. So, British Columbia, for instance, they decide themselves what kind of stuff they want to fund, even though the government says, we think it should be like this and this, but they largely decide within their healthcare system how to spend the money. And it's the same in Australia. The hospitals are run by the states, and it's not run by the government. Whereas your system is very centralized, and therefore it does not necessarily address the problems that you have on a local level.
Yeah, thank you for the answer, Mr. Kim. I hope that the answer is enough. We have two raised hands, Nurse Autry and Nurse Grace. Are there any questions from Nurse Autry and Nurse Grace to Mr. Han Soo Kim? Yes, please, Nurse Autry. Can you unmute?
Okay, thank you, moderator.
Okay.
I have some questions to Mr. Han Soo Kim regarding to your topic, health economics. Maybe I go sharp to hospital setting. During a pandemic, supposed to be hospital will get a benefit of this pandemic because based on science said that pandemic virus COVID-19 should be treated by antiviral. But in fact, that many hospitals still experience of giving antibiotic in hospital. So based on your experience, how to manage antibiotic during the pandemic? This is my question. Because until now, antibiotics still uncontrolled in many hospitals? Thank you.
Yeah, so let me say this first, right? I mean, prevention is, within the Western world, prevention is the cornerstone of the management of COVID, right? And so that's why there's so much focus on vaccination and getting vaccination rates up. And now, as you know, there's talk about boosting, a booster as well, and even vaccinating kids. So I think the latest is they want to vaccinate less than 5 years old, right, or 6 years old. And antivirals, we do have a couple. You probably know of these that have been recently approved by the US FDA. The evidence base, unfortunately, for antibiotics is not a clear-cut case. And so we have also anecdotal evidence that some of the, I think the BDOT maps actually help for cytokine storm and so on, but we don't have, from an evidence perspective, it's not clear for us. And so here in Australia, mainly we try to give them antivirals to treat, but there's this combination of lack of evidence, but also it's difficult to get stock of the drug because worldwide everyone wants it. And so we are still really trying to sit in a space where we want people to get vaccinated because we know they're not going to go to hospital if they get sick, and B, restrictions on people who are not vaccinated. And that's very controversial because then people who are not vaccinated, and they have their own reasons, they're being shut out of the financial economy, and obviously people need to work and earn money and so on. Yeah, I'm sorry, I don't have a lot of evidence in terms of the antibiotics here in the Western world. That's not what we use. Yeah.
Nurse Autry, are there any? Okay, thank you, Nurse Autry. Thank you, Mr. Hansu Kim. And maybe still there's space for 1 or 2 more questions. Continuing the statement of Mr. Hansu Kim that Indonesia is a very big country and also full of diversity from one tribe to another. As healthcare providers, we know that prevention and promotion is the answer to lowering the nation's morbidity, but from now, we know that Indonesia's health budget is still bigger in curative and rehabilitation. What can we do as healthcare providers to help lowering the cost of Indonesia's health budget in curative and rehabilitative medications? But with that, Mr. Hansu Kim, we have 1 more raised participants that raised hands. Ms. Grace, Nurse Grace. Nurse Grace, please, if you have any question. Nurse Grace. Nurse Grace. Maybe not yet. Mr. Kim, can you hear my voice?
Yeah.
Clearly? Okay. So how can we do as healthcare to help this government lowering the budget of the curative and rehabilitative budgets on Indonesia's healthcare systems? What do you think from your perspective, Mr. Kim?
Yeah, so at the end of the day, the government sits on the funds, right? So I think advocacy is a good way to go, and And when you advocate for something, either growing the healthcare budget or whatever, from sort of an evidence perspective, what we like to do is to highlight a clinical need, right? So I don't know how much your public health researchers are engaging with the government and with the hospital itself, but I would imagine doing studies in terms of clinical need studies in the future, what will happen, do we have enough? So we talk about capacity and capability, right? So do we have the right capability and the right capacity to take care of these challenges in a probably ongoing COVID world the next few years? And the answer is no, right? So here in Australia, what has happened is the hospitals has now gotten the state governments involved, and the state government is now trying to lobby the Commonwealth government to get more funding to hospitals in Australia, right? So you sort of have to go that way, but you need evidence, obviously, for them to be able to act on it. And so I think it's unfortunately one of those things where it's not scientific anymore. It's a political advocacy problem, right? So that's where I would imagine medical association would have had something to say, pharmaceutical association, the nurse association, together with the hospital leadership and the School of Public Health and so on, right? You sort of all need to message the same thing. This is going to be an issue for going forward.
Thank you, Mr. Kim, and I hope your answer has answered the questions given by anonymous participant. And Nurse Grace, is there any questions that from one of the participants that raised hands? Nurse Grace?
Dr. Sekina, maybe Nurse Grace not deliberate to tap the raise hand.
Oh, okay, Dr. Jimmy. Then we can. Do we still have? Oh, Dr. Jimmy, have any question, Doc?
Could I comment to Hansel Kim? Hello, Hansel.
Hi, Jimmy.
I'm delighted because you attend here and exchange to your experience and your knowledge to our hospital and all participant attending here. And then I remember I visit to your house on November 2010, maybe?
Many years ago, yes.
Warm greeting to Lisa and your son.
Thank you.
I agree with your mention about the hospital now must switch to services for the intervention services to the minimal invasive surgery, because that is a very efficient even to hospital and then to patient. I'm agree that is. Thank you, Hansel.
Thank you.
Thank you, Dr. Jimmy Panlewan, surgeon, our chief of Kandou General Hospital, for the comments to our speaker, Mr. Kim Han-soo. And since the time has run out, although I still have lots of questions from a few questions from the participants, so maybe we can wrap up the first presentation for today. Thank you for Mr. Han-soo Kim to share the knowledge about health economics to our international scientific meeting today. And as the conclusion, maybe I can conclude that Indonesia, with a big and with a large population of people, we still have a lot of burden in health budgets, but altogether with by the government and also by the healthcare providers, healthcare specialists, and pharmaceuticals, and all aspects that's involved in healthcare industries in Indonesia, in the healthcare industry in Indonesia. If we can walk through this together, maybe the funding mechanism will be solved, and we can give better healthcare services to all the nations in Indonesia. Thank you, Mr. Kim Han-soo. And now we are going to enter to our next speaker, to our last speaker today, Professor Ne-Ying Ko. Has Professor Ne-Ying Ko joined us? Good morning, Professor.
Hi, morning. Yeah, I'm online now.
Ni hao, Professor Ko.
Hi, how are you? Yeah, okay.
Hi,
So
Professor Ko. I will introduce you first before we start the presentation. And before that, the organizing committee would like to thank Nurse Autri Mandagi to facilitate Professor Ko for being one of the speakers today. Thank you very much, Nurse Autri. Nurse Autri is one of Professor Ko's students in postgraduate studies in Taiwan. And before the presentation, I would like to read Professor Ko's curriculum vitae. Professor Ne-Ying Ko, or Professor Monica Ko, is a professor and director of Department of Nursing in National Cheng Kung University, with research specializations include health behavior and health disparities, with special emphasis on vulnerable populations affected by HIV/AIDS and emerging infectious disease. Professor Ko is also key advisor to the Ministry of Health and Welfare Taiwan Center of Disease Control and Ministry of Education on HIV/AIDS issues. She is also a researcher and activist in advocacy, prevention, and care for persons at risk for emerging infectious disease. And Professor Ko is also a leader of interdisciplinary teams to develop innovative technology devices, Heart Thermo. And she is trained in the Leadership for Change, or LFCTM program, and joined ICN Global Nursing Leadership Institute in 2016. She's also a delegation of ICN, the World Health Assembly, in 2017, and triad meeting of ICN and WHO in 2018. Dr. Ko contributed on global health and achieving sustainable development goals in training and empowering healthcare professionals and future nurse leaders from China, Kenya, Indonesia, Myanmar, Vietnam, in disaster management, leadership, and prevention and clinical care. She was a certified LFC trainer and provided training for nurse leaders from these countries. She's also has contributed on many journals as authors or co-authors for more than 200 scientific publications, including several textbooks. That's a brief curriculum vitae for Professor Monica Ko. And as the previous session. In this session, we also have two sessions. Yeah, that's the presentation session and Q&A session. So the questions can be posted on the Q&A box on your Zoom or on YouTube. If you're streaming on YouTube, please put it in the comment section. Thank you. And the stage is yours, Professor Cole, please.
Thank you for your introduction. Yeah, can everyone hear me clearly?
Yes, Professor.
Okay.
Clearly,
great.
Professor.
Okay, great. It's my great honor to be invited as a speaker to share with you the multidisciplinary collaboration and the health system during COVID-19 pandemic. So I would like to share Taiwan experience. As your previous introduction, yeah, I am the expert of HIV because, you know, in early 1990s, HIV is an emerging infectious disease, which means it is a new virus and caused a new disease and across country, so that become a pandemic. And since then, I'm working with different kind of emerging disease, including SARS, MERS-CoV, H1N1, and re-emerging infectious disease like dengue virus, and until now, COVID-19. So I was recognized by International Council of Nursing as HIV expert. And during the COVID-19, I also key consultant in different major cities like Tainan City and Kaohsiung City in South. So I just to share with you, as I learned the new normal become the caring and learning without border during and after COVID-19. And you will see the picture. Yeah, here is the infectious ward in National Cheng Kung University Hospital. As all of you know, Taiwan is a very successful model for well-controlled COVID-19. So you will see in this year, before May, actually we have achieved almost 1 year, 252 days without local coronavirus cases. Yeah, but okay. But I think how do we do that? Because we have a Taiwan model. We have been experienced SARS. Based on the lesson we learned from SARS, so we know how to communicate with our citizens. And also we apply the new technology to control the pandemic. However, you will see there is a peak. Yeah, in around like May, middle of May, we aware that is some cases or some small outbreak in North Taiwan, and that become a community outbreak, and that is a peak surge up. So you will see we already achieved 252 days, 0 local case, but we picked to per day, 300 more cases was confirmed. And then, however, and we successfully control back to 0 within 108 days. Yeah, so many people, many countries ask us, how do we do that? I think I would like to share with you.
It is our duty as global citizens to give them our full support. Pandemics cannot be stopped by one country alone, and Taiwan stands ready to do our part.
Yeah, so you can hear, and I just want to mention that, how do we come back and win the battle? I think the most important is we stand together. Not only healthcare system, we also work with different disciplines. And for example, like military and police department, and also every essential workers across different area. So stick together and then we can fight and win the battle. So start from outbreak, early May, and until August. Taiwan back to 0 local case. Many people ask me, how about healthcare workers? Fortunately, in Taiwan, no nurses or doctor died from COVID-19 during the pandemic. Even we have more than 50 nurses or around 100 healthcare workers infected with the virus. And how do we do that? I think education is quite important. So we invite like the Olympic athlete to demonstrate how do we keep social distance every hour in our television. So the public risk communication, and also invite the key opinion leader, KOL, that is quite important. And I think many people to know how important during the community outbreak, stay home is so important. But we didn't lock down even during community outbreak in Taiwan. But you will see that is May this year. So you will see there is no people on the street. How come? Because people, they self-discipline. So we have good citizens. We obey and we follow the commander's suggestion, and they self-discipline. And also this year, we during pandemic, we do have precision epidemic investigation. We have a detailed tracking system, and we have hot map. And we're using the cell phone to identify where you are. So in Taiwan, if you go into the convenience store, you have to scan, and then we will know who and when and how long you stay in each public setting. So you will see that is the informatics system, geographic informatics system that can quickly recognize where you are, how many in there, and that will send a group message and to warn if they people was confirmed. During pandemic, we provide COVID-19 home test. And also we boost the vaccination. So that is the today's data from our in-data system. So you will see in Taiwan so far, the full vaccination is around 40%, but one dose or partial dose vaccinated is around 74%. So yeah, the rate of vaccination is boosted very quickly in Taiwan. And you will see that is Statorian, yeah, and we have a massive vaccination setting, and not only we regulate and then to have a follow-up guideline, but we also invite musicians, yeah, to relieve the anxiety when you're waiting for the vaccine. So you will see that is the Kaohsiung Music Center, and then we have a regulate and also display some music. For example, like in that time, many other elderly people come, so we play some old-fashioned, old-school music to calm down their anxiety and then make them feel more relaxed. Yeah. So I think as the university, especially National Chongqing University, this year is our 90th anniversary, and as a comprehensive and we have the 9 college. So we work together to protect our city, to protect our nation. I think that is important, is the university responsibility to work together. So this film shows that during COVID-19, how different disciplines work together, and then based on research from NCKU perspective.
我想2020年对所有人的冲击，绝对不会离开一个戴着口罩的防疫年的记忆跟影像。从台湾地区出现第一个确诊案例，接着武汉封城，国际疫情蔓延到几乎失控，许许多多的国家仍然处于高度的紧绷状态，持续还在跟疫情奋战。如果你要问我对这一年有什么感想，我会说是十分忙碌，可是也无比幸运。因为在这个疫情当中，所有的第一的挑战都给了成功大学去面对跟回应。台南地区的第一个案例，也是大学校园中第一个疑似案例的出现，就发生在我们学校。而这个看到嗅味觉异常感染的患者，也出现在成大医院。又例如像敦睦舰队官兵，
And there is a military outbreak. The first case was also happened in NCKU.
因为全台湾大概只有成功大学
And
可以
SKU
有效率
become
的
the
跨
very
领域连
important
接资讯，
university to
结
help
合医学
city
中心的量能，
to
并
help
且快
country
速
to
而
fight
正确的
with
去
the
反应
pandemic.
跟调整。
We
勇
not
敢
only
的、
have a
试探性
hospital,
的、史无前例的决定，
we also
这
have
就是回溯到
different
2020年
area
的1月，
major.
我们是第一个在教育部的决定之前就宣布延后2周开学的学校，也建构了全国第一个由大学完全自治自办的检疫宿舍。
Now we have the
我们更有
first
效率的建构了数位平台，及时的、
platform.
到位的、有意
And
义
also
的
this
分
is
享了我
our
们的智
station
慧与经验。
to apply how to we do quarantine. And we information technology to apply to track every student in campus. And that is a dashboard
幸运
to
不会
all
忽然从
over
天上
our
掉下来，
campus.
那是数十年来累积的知识量能，回应了国家在
The
关键时刻
biology,
防疫
the
的需求。
hospital,
我们
the
降低了城市
technology,
巨
the
户的风险，
architecture,
我们
different
也减少了
disciplines work
民众的焦
together.
虑，让我们知道面对冲击，我们必须有更前瞻的思维，
And we'll
而依赖
apply
着知识，
artificial
我们一
intelligence
步一脚印，稳健的走过
to
这场危机与
have
挑
a
战。
new
以知识为光，我们
algorithm
看见未来的道路。 那道有意义的光，有分量的支持，让我们在责任的承担中，体会到有能力去贡献和服务，是至高的荣耀，是无可比拟的幸福。
I think that is important as a university hospital to take on our responsibility to protect our city, our nation. Yeah, so this is the data from NCKU Hospital. Yeah, we can provide the rapid test, PCR test, like 3,000 a day. And we can vaccinate people a day around 10,000. Yeah, so in NCKU, not only in NCKU, including the NCKU hospital, we just stay together to help and to protect people. Yeah, so who is the hero stand on the front line during the COVID-19? I think I just want to raise our team and to become an example to share with you. I'm the team leader and I work with different professors from like the computer science and the information engineering and also from mathematics. And working with our hospital, the vice president, and also the chief of infection control in South area, and other the professor and doctor expert in infectious disease. And we also develop, we also cultivate future leaders like Dr. Ye and Dr. Chen, all two of ladies. Yeah, graduate from Department of Nursing, but they work in hospital and work in infectious, work in computer science and informatics. It's like a cross discipline to work together to innovate the new way, new method to protect, to do the infectious disease. Our discipline is start from 5 years ago. Yeah, there was a dengue epidemic re-emergent as a community outbreak in 2015 that became the biggest outbreak of dengue fever in Taiwan. And we started thinking using the new perspective. We applied the information technology, geographic information technology together. And we, since then, we are using crowdsourcing and using the GPS identification to do the tracking. And then we using the new idea like OV-Trap, we put a chip and then we can remote can follow and monitor remotely. And then we started thinking, how do we use in a wearable device? So working with team, we develop a new idea is a heart thermal. Yeah, that is a wearable device to measure the skin temperature to do some prediction. And then, yeah, we win a war. And you know, before and during a COVID-19 outbreak, we just apply it in different population.
Professor Ko, excuse me, the time is 5 more minutes for your presentation. I'm sorry to interrupt you, please.
Okay. Yeah, so you will see that is our teamwork. And this, the tank on the central photo, you will see, yeah, that is a mobile tank. And people can get tests. And then we can use in the new technology, the light, to disinfection the area. And we also can dry as a trunk and then go to different area to provide the instant care. Yeah. And you will see this is our new innovation, how to apply. Yeah, so people stay in the hospital, they can wear a device, and then we can remotely monitor the situation. The healthcare worker, manager, or even their family can use in their mobile phone to monitor their situation. And then we can apply artificial intelligence and to early detection, what is the difference and how people get worse. Yeah, if we find the people have the sign to get worse, we can send them to the hospital. Yeah, so because in the old time, people have fever, we just using the temperature to double check, but this is like just take it when you are fever. But right now we have the heart thermal, and then we can have the real-time monitor, and then we can do some prediction. So the body temperature become the early detection infectious disease in our system. So you will see we have many journalists to report, and we really apply the real situation, like patient in isolation room or student in quarantine or the frontline workers. And then right now we apply to the quarantine hotel and other long-term care facility. So that become a new concept. And then you will see from the heart thermal, and then we put different device, and then we can do the early detection and then do the report. So right now that become the integrated service framework, and we already have make that possible. So you will see we have applied that, and then we have successful outcome, and those results has been published. Yeah, so I think that is very important. We not only using the system, we can increase the completion rate of body temperature check. We also can decrease the case. And then if there have some change or have become critical situation, we can early to detect and transport to the hospital. Yeah, so the end, I would like to say, in the face of an unpredictable virus, human beings can only address the challenge with humanity, and nurses become the core and value and the major role to face and become the hero. Thank you. That is my presentation today.
Thank you for Professor Monica, for the presentation. And next we will enter the Q&A session. For our information that we are now being streamed by more than 850 participants. And the first question from anonymous participant. What is your opinion for other country besides Taiwan? What we should prepare for maybe for the next wave of the pandemic or other pandemic to come? What is the most important thing to be prepared for facing the pandemic? Please, Professor Cole.
Yeah, I think the first important thing is to identify what is the rule and how do we follow the rule. You know, the new virus always unpredictable, and you don't know how to follow that. But based on this COVID-19 pandemic, we will know the self-protection will be the first important thing we need to do. So based on different route of infection, the airborne, the bloodborne, and the vector-borne. Also depends on different route of infection. We need to know how to protect self. And the second, because as a healthcare provider, you need to protect yourself, and then you can protect your patient and your family. So I always say follow the major of infection control principle. That is very important. And the third is the transparency, risk communication. Yeah, so don't hear the rumor. Yeah, you respect health professionals' advice, and then to communicate with your student, patient, family, and community people will let them know how to protect themselves. Yeah, this is my answer.
Thank you, Professor Ko. The second one is, how should a good health defense system built in a country, in your opinion, to face such things as pandemic?
Yeah, I remember the early 2020, and many hospitals ask the same question. I always tell them two important things you need to prepare. One is the manpower, sufficient manpower. And second is sufficient material per the PPE, the mask, and anything you can apply to protect the frontline worker. If you have sufficient manpower and have got the people's trust. Okay, that's my.
Professor Ko?
Hi.
Excuse me, okay. Professor Ko?
Hi. Yeah.
Okay, hi. You can hear us clearly, okay. Thank you for the answer, Professor Ko. And if there is any participant who wants to ask questions to Professor Ko, please raise your hands.
Yeah, Andrew.
Andre Watulingas, please unmute yourself and Andre Watulingas.
Okay, thank you, Professor. Thank you, Professor, and thank you, Dr. Sekina. My question is actually pretty simple and common. I just want to know, in your perspective, so what is gonna be? What is gonna be after this pandemic ends? Like, what is gonna be your main goal in health department? Thank you, Professor.
Okay, I think that is a very important and key question. Yeah, I would say, how do we back to new normal? And then I have a three concepts. The one is resilience. Yeah, how do we to help our front worker, healthcare worker, college student, and also the faculty back to their normal? I think the resilience is important. And the second is what is the need to recover? Yeah, because so many people was impacted and has been even traumatized by this COVID-19, how they recovery from this experience. And the third is renormalization. Yeah, how do we get back to the new normal? What did they need? And how do they stay with the new technology? Yeah, so that is 3R. The first R is resilience, and the second is recovery, and then third is renormalization. Yeah, that is my answer.
Thank you, Professor Ko, and thank you, Andre. Are there any participants that wants to raise hands and ask the questions live? If there are none, I will read the questions from the anonymous participants. Professor Ko, as we know, in vaccination terms, there are some people that we call non-supportive group or skeptic people about vaccination, especially about COVID vaccination. Are there any kinds of groups in Taiwan also, Professor Ko?
Oh, yeah, sure. Sure. The hesitancy of vaccination is a global issue. Yeah, so that's why we invite, so make the information like clear and communicate with those misinformation and disinformation are quite important. Yeah, so I want to clarify some information if I hear and I receive from for example, my cell phone, the app, the social media. So you need to verify them and make the correct information be delivered. That is important. Yeah, so many people from different areas always ask me, is the vaccine workable? I always say yes, no matter how. Yeah, of course, it works. Yeah. The vaccine is
mengerti. Terjemahkan kemarin. Dah ikut
please mute yourself. Okay. Thank you, Professor Ko, and such an inspiring way to convince people to reduce their hesitancy to go to vaccination. And Nurse Audrey has raised hands. Please, Nurse Audrey.
Hi, Audrey.
Thank you. It's kind of pleasure to see you again, Professor. But in this time, I would like to ask you some opinion or some knowledge regarding to multidisciplinary involved in handle a pandemic. As your presentation said that one of the core component is IT, technology. It's we should thanks to the technology, especially in Taiwan, because you have a good technology. That's why the pandemic was calmed down in Taiwan. My questions now is how far the professional or the academic contribute or involved in this pandemic. Thank you.
Okay, I think Audrey, we always can work together. Okay, yeah, like I invented the new technology, and right now I apply to my graduate, like Ikabo. Yeah, he graduate. Yeah, and then we start to work together, and then we can share our new technology and have a cross-country collaboration. And as a professor in academic, I think I'm also a clinician. I work very closely and also work in hospital. So I think as an academician, how do you know what is the essential need? You need to stand on the front line and listen to healthcare worker or others. What do they need? And then trace back to your research or your discipline based on your major to help them. For example, that I share with you Hasumo, because you know that is, yeah, this is from nursing, because all we know the vital signs are so important. So infectious disease, people have fever, right? So I just applied a new technology to answer the old-fashioned, the core question. Yeah, So you work with, I would say, yeah, IT, you need to find a right partner, because I really have a good collaborator and partner, start from 2015. And then we work until now. It's not like a one-time shop, one snake shop. You can find. You need to work together and for a long time, and then build up, accumulate those those knowledge, and then apply the right time. Yeah, I don't know. Yeah, am I answering your question? Yeah.
Thank you, Professor.
Yeah, we can work. We can collaborate together. Yeah.
Thank you, Professor Ko, for the answer. And Nurse 3, I hope that's your question. And also, because it's run out, we have to end this last session of the scientific meeting today. Thank you, Professor Ko. And may I conclude your presentation today about multidisciplinary collaboration and healthcare system during COVID-19 pandemic is that COVID-19 has changed a global perspective in healthcare system, and a good collaboration between the government and all healthcare providers can together and hopefully this pandemic soon enough all of us. Thank you for such a great representation. Thank you for sharing the knowledge, Professor Dr. Ardi Kapitulmanan. And thank you for all the participants that has us from walk through the closing ceremony. Here pardon the connection. Thank you for all the speakers, from the keynote speaker, our chairman, our chief director of Ardo Hospital, surgeon, consultant of digestive surgery, and also for our international speakers, Mr. Han-Soo Kim and Professor Monica Ko. Now we will go through the closing ceremony, and the closing speech will be presented by our Vice Chairman of the Organizing Committee, Dr. Erwin Kristanto, Specialist Forensic, SH. Please, Dr. Erwin.
Thank you, Dr. Sekina. I would like to thank our speaker, Mr. Han-Soo Kim and Professor Monica Ko, for their wonderful work. I would also like to thank our Board of Supervisory Board, Professor Allen, We are sorry that our Chief Executive Director, Dr. Jimmy Panalavan, could not be with us in this moment because other tasks that he has to do right now. I would like to thank to all our viewers that has been with us from the morning that we start this webinar until now. Our wonderful team that organized this webinar so it can run as we hope. We hope that starting from this year, we will do this seminar year after year continuously. And we hope that this webinar will profit our medical doctors, our health workers around Manado, around Indonesia, and around the world. Thank you for viewers from Australia. I see a lot of them in our list. Again, I will thank you for your cooperation and your participation across this webinar. On behalf of our directors, I will close this webinar, and all of our consecutive webinar, national and local, that we've made from this week and the week before. We thank you. May God all be with us. Thank you.
Thank you, Dr. Erwin Kristanto, for the closing speech. And finally, thank you for all speakers, contributors, organizing committees, and also participants that has joined us from the morning until now. The closing speech from the Vice Chairman of Organizing Committee has led us to the end of our scientific meeting today. Thank you for joining us in Kandou Virtual Scientific Meeting. And see you later on the next event. May we all have a good day, and may God be with us all the time. Shalom. Good day to all of us.
Thank you.